Welcome to Tuesday Morning Grand Rounds. It's my privilege this morning to introduce our speaker, Dr. Damon Dixon. Dr. Dixon has been a PCH cardiologist on staff for about 8 years now. He covers multiple clinical sites, including Yuma, Kingman, Flagstaff, and Valleywise. Dr. Dixon went to medical school at the University of North Dakota School of Medicine and then did a residency at the Medical University of South Carolina. And prior to his cardiology fellowship, he served as a general pediatrician for 6 years in the Indian Health Service in both Nevada and Arizona. Dr. Dixon is a previous member of the AAP Committee on Native American Child Health and did his cardiology fellowship at the University of Minnesota. And then he did a special interest cardiology fellowship in preventative cardiology that includes obesity, hypertension, dyslipidemia, and insulin resistance. Dr. Dixon's a member of the National Lipid Association and a member of the NLA Committee on Pediatric Dyslipidemia. He's published articles on pediatric lipid screening, implementation and imaging techniques in pediatric dyslipidemia. He serves on the medical board for emerging lipid biotech company in the development of new cholesterol medications. He's a member of the PCH Obesity Interest Group and a member of the PCH Developing Bariatric Program. And in his free time, he enjoys playing soccer and a member of the PCH cardiology soccer team and enjoys hip hop dancing on Monday nights. So Dr. Dixon, welcome.
Yes, you did hear that right. Dancing is part of some of my accolade things that I do. In fact, I have one of our fellows who actually joined us in our dance class a couple years ago, but I am excited to be here. So here's the code for everybody. And what we're going to talk about today is the 2026 newly released American Heart Association scientific guideline on pediatric hyperglyceridemia, which is super important because this is the most common pediatric lipid pattern that we see in the pediatric outpatient world. And then as John mentioned, another title that I hold is I'm the director of our Native Indigenous Health programs at the College of Medicine. And it was really my time as a pediatrician on the reservations where I gained my insight and my expertise on lipid management due to the high prevalence of metabolic dysfunction on the reservations. Some of you may not necessarily know, but it's actually been a pretty exciting time in the cardiometabolic world the last 2 years. Starting off with the release of the updates of the Pediatric Obesity Guideline by the American Academy of Pediatrics, new hypertension guidelines, the FDA approval of weight loss medications, mainly with GLP-1s, an update of familial hypercholesterolemia guidelines that also pertains to pediatrics. And then just recently in the last month was the updated adult cholesterol guideline, which the last ones were released in 2018. But the adults now are really starting to recognize pediatric dyslipidemia. And so they have a sprinkle of recommendations for the pediatric world. And then just recently, like I mentioned here, what we're talking about today is the American Heart Association's guideline on high cholesterol in pediatrics. And I should mention, actually, the last global lipid guideline was in 2011. So we are due for a global updated dyslipidemia guideline for pediatrics. Here are my disclosures, which are none. And these are objectives. We have 3 of them. So it really just helps you gain an understanding of how we classify high triglycerides in the outpatient world, which is important because it helps to dictate our treatment pathways. And then to help us to also recognize genetic dyslipidemias in the terms of high triglycerides. We're very good at identifying high LDL cholesterol, but when should we worry about those patterns when the triglycerides are high? And really try to understand and how to calculate non-HDL, which is an important lipid biomarker that we use in our decision-making to start a cholesterol medication in the setting of high triglycerides. So we have to have a question, and I'll just introduce the question here, and then we will answer it at the end. So 11-year-old that we would see in the outpatient clinic, family history is known for obesity, hypertension, and high cholesterol. There's no family history of early heart attacks or diabetes. And the mom was recently started on the cholesterol medications. So from that history, you sent out a screening lipid panel, and the lipid values are elevated. And so we're mainly focused on high triglycerides. And so there you can see what we get. And so that the triglycerides are 233. So the question, which is a two-part question, is what additional lipid biomarker would be indicated to evaluate subclinical atherogenic particles? And what pharmacotherapy would be indicated when you're measuring those biomarkers? And so here we have 6 choices. It's a loaded question, but hopefully at the end of the talk, we will be able to answer this. So as pediatricians, why should we care about cholesterol? Because the most common cause of death in the United States and in the world is cardiovascular disease, and cholesterol plays a big part in that. And the substrate for that process is the fatty streak, and this develops in childhood. So prior to the 1990s, and before the onset of obesity, it was thought that the fatty streak didn't develop anywhere from between 14 and 18 years of age. But after obesity in the 1990s, it was shown in autopsy studies that it actually started to develop between 4 to 6 years of age. One of the nice characteristics about the fatty streak is that it's actually reversible. And so what we have to do as pediatricians, we have to implement 2 prevention strategies to reduce the risk factors that develop the fatty streak. And the traditional risk factors are high cholesterol, obesity, high blood pressure, smoking, no physical activity, and a poor diet. And the way that we approach these in terms of our 2 prevention strategies are primordial prevention and primary prevention. Primordial prevention is where we are trying to not let these risk factors actually develop. And we're trying to control our social determinants of health in the community so these risk factors don't develop. In terms of primary prevention, which means that the risk factors have actually developed. And so we're trying to prevent those risk factors progressing to a disease state. And so what we do, we have to develop these protective factors. So the things that we do here at PCH is develop an obesity clinic, like our care clinic, where they have established risk factors, but we're trying to prevent them to develop insulin resistance and obesity that has comorbidities. So another reason why it's important for pediatricians to know about cholesterol is most pediatricians in general are pretty uncomfortable managing dyslipidemia in the pediatric world. So 2 years after the release of the 2011 pediatric guidelines, I sent out a survey to over 1,000 pediatricians in the state of Minnesota. And I wanted to look at what their knowledge and awareness and what their implementation strategy was with the release of these new guidelines. And what we found was actually pretty interesting. But in general, most pediatricians thought it was important for us to screen for cholesterol, but they were pretty indifferent on whether or not they should use a cholesterol medication, i.e. a statin, on children. They did not know the normal and abnormal values. And most of them were pretty uncomfortable managing dyslipidemia in pediatrics. And at that time, no pediatrician had ever started cholesterol medication on a child. And then lastly, an additional factor is I think we have biases that we hear from the adult lipid world and also from our own experiences from our own if we do have high cholesterol. But the biggest difference between the pediatric world and the adult world is what are these risk calculators. So in the adult world, they use these risk calculators, and it's called the PREVENT calculator. So if you go to the American Heart Association, and it's now recommended, if you're 30 and above, you can put all your data and metrics into this, and it looks at cardiovascular, kidney, metabolic, and social determinants of health. And it's actually nice because you can actually put in your zip code, and it gives you a risk assessment of you individually, what your risk is of having a cardiovascular event in the future. And it gives a 10 and a 30-year risk. And so that's the biggest difference in the adult world from the pediatric world, because in the pediatric world, we don't have this risk calculator because it would have to be a global lifetime risk, and we can't do that in pediatrics. So unless a kid has the highest risk factors like diabetes or monogenic dyslipidemia, we're not able to estimate those risks in pediatrics. So most people don't know that there actually been a lot of previous guidelines in the past for pediatrics in terms of dyslipidemia. And so I made this little table here just showing all the different guidelines, how it has progressed over the years. But most people don't know that the reason why we became interested and aware of dyslipidemia in pediatrics actually started in the Korean and Vietnam Wars, when young military men who were killed in the war, who died, had autopsy studies. And when they did those autopsy studies, they found that a lot of them had dyslipidemia in their vessels. And so this provoked two big giant pediatric cohort studies, which are called the Bogalusa study, which is a town in Bogalusa, Louisiana, and the Muscatine study, which is in Muscatine, Iowa. And it was these studies that developed epidemiological big cohorts, looking at imaging and looking at autopsy studies that really kind of dictated the development of these pediatric lipid guidelines. So there were actually 4 total that started in 1992. And then the other factor was we had the epidemic of obesity. And it kind of merged all the way till 2011. And 2011 was the last global pediatric dyslipidemia guideline, where it made its most controversial recommendation. And that recommendation was that all children between 9 and 11, it was recommended they have universal screening of cholesterol. And that was regardless of risk factors, risk conditions, and family history. It was endorsed by the American Academy of Pediatrics and is also endorsed by the National Lipid Association, which also put out another guideline too in 2015. And then in 2018 was the last adult cholesterol guideline. And again, it had a little bit of sprinkle of some pediatrics in it, mainly just talking about universal screening. And then fast forward to 2025 and 2026, where we are now. 2025 was the last familial hypercholesterolemia update, which had a lot of pediatrics in there, which is very useful. But here we are in 2026, and this last month was the last updated adult cholesterol guidelines, which we'll talk about a little bit because it has some pediatrics in it. But here today, we're really talking about the release of the Pediatric Hypertriglyceridemia by the American Heart Association. So briefly, as I mentioned before, the last global pediatric lipid guideline was 2011, so that was about 15 years ago. The primary strategies, looking at prevention strategies, we talked about primordial and primary prevention. Its controversial recommendation was universal screening. Again, regardless of risk factors, risk conditions, and family history, all children between 9 and 11, it's recommended that they go have a lipid screening. And the reason for this, the main reason was for us was to recognize genetic dyslipidemia or monogenic dyslipidemia, mainly with LDL cholesterol, which is familial hypercholesterolemia. It laid down the foundations a little bit for triglyceride management, but it was very loose. And so it was very confusing on what those thresholds and pathways in terms of when should we treat for high triglycerides in pediatrics. So that's the beauty of this new updated guideline. It really sets these nice pathways, and it kind of answers those questions, because I think it's very confusing for the outpatient pediatrician to know, when should I start a medication? And so we'll see those guidelines and we'll see those pathways. This is the normal and abnormal table from the 2011 lipid guideline. And I have a couple of things that are highlighted there. So one, the purple part right here, and that's the triglyceride normal and abnormal values. The table is broken down, divided into 3 categories: acceptable, borderline, and high. So for us, what we really care about is at the high, which is usually greater than the 95th percentile for the pediatric population. I mean, you can see it has different values from 100 to 130. As a whole, for me, I usually use about 150, but from the pediatric guideline, they use 130. But there's a whole nother level to that. So I have it there on the side. It says levels of severity. So you'll see only for high triglycerides, there's actually a whole nother table. And that's why managing high triglycerides is a little bit confusing. But again, this new guideline has nice new tables that makes everything, I think, a little bit more clear. The other thing I want you to pay attention to, which I have highlighted in the red by the star, is non-HDL and ApoB. And those are very important because those are surrogate biomarkers that we use that really recognizes atherogenic particles. And that's actually what we really, really care about. And again, this is what the guideline shows. So I just wanted you guys to see that. And actually we have normal and abnormal values in pediatrics. So it's those values have been there for a while.
Somebody asked, do the labs need to be fasting?
So I should say that's the preferred. The decision for treatment is based on fasting lipid levels, not non-fasting. So here's a couple of little clinical pearls. So with the table here, as I mentioned before, I'll come back here for a second. As I mentioned, the table that they have is divided into three separate categories: acceptable, borderline, and high. And so the nice clinical pearl here that I want everybody to know is that the labs that we order from SonoraQuest and LabCorp, its upper levels are really based on the acceptable and optimal levels. And so what happens here, so I took a picture of this because this is a patient that I saw just yesterday. What happens is the pediatrician orders the labs, and then they see all these red highlighted, bolded areas. But the levels that they use for abnormal are really based on the acceptable range, not the high range. And so oftentimes when they come to see me, I see them, I'm like, they're actually normal because they're not considered greater than the 95th percentile. So that's a great clinical pearl to know. So there you can see, so triglycerides, you can see here that the upper level, they have 89, but it was 96. So it's all lit up, 96, but really the true value for it is greater than 130. So it's actually kind of in the normal range. So same thing, non-HDL is greater than 145 and it's 132 on this patient, and the LDL cholesterol is 110 and the upper threshold for abnormal is 130. So that's something important for the pediatrician to know. The other thing is the most common cause of high triglycerides I see in the outpatient world is that they just weren't fasting. And here again, I have it circled here. If you look on the little lab thing, you can see sometimes where it says fasting or non-fasting. Because a lot of times what happens a lot is mom or dad took the child to get the labs done. And so they come and then it may say fasting and it'll say no. So then I'll ask them like, did you eat? And the kid's like, oh yeah, dad took me to McDonald's before we got the labs. And they're like, oh, okay, well, then we just need to repeat it. And I would say 6 out of 10 times you repeat it and it's normal. So then there's nothing that you have to do about it. But again, I understand from the pediatric outpatient world that, you know, they get the labs and it's red, or the nurse practitioner sees them and it says, oh yeah, they need to go see cardiology because they see all these red bolded lipid values. The most common cause of high triglycerides, metabolic dysfunction, insulin resistance, obesity. That's what really needs to be managed. Higher states of triglycerides in the 200 to 300s. You want to make sure you always send for hemoglobin A1C. I can't tell you how many times I've diagnosed a new type 2 diabetic. And so really the treatment is insulin. They don't need cholesterol medication. Check the thyroid. And then Accutane. Pretty common. I see a lot of kids that were put on Accutane and they have residual high triglycerides. So very common. Usually in general, most of the time, once the Accutane is stopped, their triglycerides will get better. So this is a table to look at the temporal trends of cholesterol in the United States. So it's estimated anywhere from 10 to 20% that kids can have some sort of dyslipidemia pattern. Even though in this table here, it looks like the values are going down, newer cohort numbers have suggested, especially after COVID, the numbers are actually starting to trend up again. The other thing that's really nice, as I mentioned before, that people are starting to track are non-HDL and ApoB. Again, as I mentioned before, these are biomarkers that we use that are really specific for atherogenic particles. And this is actually what we really, really care about. And again, those numbers are starting to trend up a little bit. The rates of elevated triglycerides are higher in populations of metabolic dysfunction, so insulin resistance, obesity. So it's been estimated anywhere from 30 to 60%, and it's pretty disproportional in other races. All right, so now I got to bring us back to organic chemistry. I put this up just to remind us that even though cholesterol has a bad reputation of atherosclerosis, cholesterol has other important roles in the body, with cell membranes and hormones. So prior to or the peri-puberty years, I try not to be too aggressive in trying to lower the cholesterol because I think cholesterol has these important roles in the body. So something to remember. So that was organic chemistry. Now I'm going to take us to our first year in medical school with biochemistry. And so when we talk about cholesterol, we're really talking about the lipoprotein structure. And this is what the basic structure looks like. And the core is really consists of a hydrophobic core of triglycerides and cholesterol esters. And so for it to able to be processed throughout the body, it needs a hydrophilic membrane so that it can be processed in the body. And attached to the membrane is what we call an apoprotein, which are cofactor protein molecules. And these are important cofactors because it helps the lipid molecule to be processed and kind of know where to go into the body. And so we'll take a close look at that. So here's a table showing the most important apoproteins, so that protein cofactor that's on the lipid membrane. And again, I highlighted two of them here. So ApoB, so there's ApoB48 and ApoB100. ApoB48 is a cofactor protein before the liver, and ApoB100 is the cofactor after the liver, after the lipid is processed and metabolized. But all you really need to know is ApoB, because ApoB is that marker for atherogenic particles. And then ApoC3. ApoC3 controls the most important enzyme in the lipid metabolism, which is LPL, which is lipoprotein lipase. And so we'll take a look at that. And the reason why this is important, because what controls ApoC and lipoprotein is metabolic dysfunction. So here is a broad overview of the lipid metabolism, which, even though it looks like it's a lot, I think it's better than the glycolysis and the Krebs cycle that we had to learn in med school. But so two pathways, the exogenous pathway and the endogenous pathway. The exogenous pathway is like we're doing here today. We eat, the dietary fat gets hydrolyzed by the intestinal lipase. That dietary fat gets packaged into chylomicrons. Those chylomicrons then get absorbed by the lymphatics and then through the thoracic duct, and it enters the circulation. It gets processed and then it gets shuttled to the liver. So that's the exogenous pathway. The endogenous pathway starts with those substrates that are shuttled to the liver, and then it's released as VLDL. The VLDL gets processed and it ends up as LDL, and then it gets shuttled back to the liver. So those are the two basic pathways. What I want you to pay particular importance to is the red circle there, the LPL. That's the lipoprotein lipase, and that's the enzyme that really controls the process of lipid metabolism. And it's an exogenous and endogenous pathway. And the other thing, as I mentioned down there, is that ApoC3. ApoC3 turns off the activity of lipoprotein lipase. And that's very important, because if it turns off lipoprotein lipase, it'll make your cholesterol go super high. So what controls those two factors? And here you go. Here's a nice little diagram showing that. Insulin and ApoC3 controls lipoprotein lipase. Okay, so if you have metabolic dysfunction or you have insulin resistance, it's going to upregulate ApoC3. So if you upregulate ApoC3, it's going to turn off your lipoprotein lipase enzyme, which means your triglycerides and your cholesterol is going to go up. So really the true management is metabolic management, insulin management. Okay, and the insulin itself has a direct effect on lipoprotein lipase. And so when that happens, you get increased levels, and then the atherogenic particles start to develop that we call triglyceride-rich lipoproteins or remnant lipoproteins. And so these are the risks for atherogenic particles. The other thing that I want to point out that most people are not aware of is the traditional lipid panel that we order from SonoraQuest and LabCorp. So total cholesterol, LDL, HDL, triglycerides are really based on large lipoproteins and density as it falls down the electrophoresis. Hence the nomenclature, high density lipoprotein, low density lipoprotein. And so these particles are considered big and dense, and so they fall down the electrophoresis. But what we have learned over the last 20, 30 years is what we really care about are the small particle dense lipoproteins. And so the thought process is that these smaller particles are able to penetrate the endothelial walls and the vessels to set up that cascade inflammation. And this is what we call atherogenic particles. So how can we recognize those risks? So we have two markers, as I mentioned before. We have non-HDL, which is beautiful because we can actually calculate that from our traditional lipid panel that we order every day. And then, or we can specifically order ApoB because ApoB is attached to every lipoprotein, or I should say every atherogenic lipoprotein. So here's a nice little table here, a nice little graph. It shows the relationship of non-HDL and ApoB. So everything here in the red little box are all your atherogenic particles. So that includes LDL cholesterol, lipoprotein little a, IDL, BLD, and chylomicrons, okay? So what we can do when you get your traditional lipid panel, you can take your total cholesterol minus your HDL, and that'll give you an estimated calculation of your atherogenic particles, and that's your non-HDL. So that's awesome. You have that, and we have normal and abnormal values. Normal value is less than 145. The big tiebreaker is ApoB is attached to every single one of these. So you can order ApoB to get an exact number of atherogenic particles. Okay. So I like to use ApoB as my tiebreaker because you can have what we call discordance, meaning that you can have normal-ish LDL or triglyceride levels, but your ApoB can be high. So in the pediatric world, we call this subclinical atherosclerosis. In the adult world, they call it residual atherosclerosis. So ApoB is the tiebreaker because it's specific. You can order it and it's attached to every atherogenic particle. So this is from the adult guidelines. So they have recommendations. So non-HDL has a good strength recommendation, and it says there right there, in adults and children who have undergone a standard lipid panel, reporting non-HDL is recommended for the risk assessment to guide initiation and monitoring lipid lowering therapy. So strong recommendation for us to utilize non-HDL to recognize the risk for atherogenic particles. ApoB has a moderate recommendation. So ApoB is very useful in metabolic dysfunction, insulin resistance, type 2 diabetes, and states of elevated triglycerides. And again, it's used to help us to guide us through medications and once our LDL and our non-HDL goals are achieved. All right, so now we can talk about the guideline. So did a lot of organic chemistry, a lot of background stuff, a lot of biochemistry, and now we can actually take that information and see how it's utilized in the guideline. So again, triglycerides are important, and this is an important guideline because this is the most common lipid pattern that we see in the pediatric world, which is usually high total cholesterol, high triglycerides and low HDL. And so this guideline really helps to make those pathways a little bit more clear. And the most common cause of high triglycerides are metabolic dysfunction, obesity, and insulin resistance. And even here, if you look here on the abstract, it says pediatric hypertriglyceridemia is common in youth because of its association with obesity and insulin resistance. Okay, so the first two lines. So when we talk about high triglycerides, it's really mostly due to metabolic dysfunctions. They don't necessarily need cholesterol medications. They need insulin management. So why do we worry about it? Theoretically, it has a risk for atherosclerosis, but really I would say it's more of a risk enhancer. Some of the new updated triglyceride studies in the pediatric world, in the adult world, haven't really shown that having super high triglycerides is the end-all effect of atherosclerosis. But again, the adult world is totally different from the pediatric world. And then the really only main cause to treat high triglycerides is because of its risk for pancreatitis. So again, you should also think about when you see someone that comes with pancreatitis, you may want to check their triglycerides. And they may have pancreatitis because they have a new onset of diabetes. So what are triglycerides? So they're the primary source of energy for the body due to the free fatty acids that are attached to the glycerol backbone. And so as I mentioned before, triglycerides are hydrolyzed and processed by lipoprotein lipase, which is the important enzyme in the lipid metabolism. And the two main lipoproteins that we worry about are chylomicrons and VLDL. That comes from the two different pathways. Super high triglycerides will put a patient at risk for pancreatitis. And again, as I mentioned before, the reason why we worry about triglycerides in terms of atherosclerotic risk is due to what we call TRLs, which are triglyceride-rich lipoproteins. And the rash that's usually associated with high triglycerides are what we call eruptive xanthomas. So here's a picture of the eruptive xanthomas. So for the outpatient pediatrician, you should make sure that when you see molluscum, that it's not an eruptive xanthomas. They can almost look the same. So yeah, usually in the trunk. Yeah. So different locations, then you would see molluscum, but sometimes they can, if they're not super red, they can just look exactly like molluscum. So high triglycerides, how do we classify them? We classify them in primary and secondary. When I see kids with high triglycerides, what I always want to do is try to rule out the most severe kind, which is the monogenic or the genetic type dyslipidemia. So monogenic dyslipidemia is usually due to a single point mutation that has a high effect phenotype. So the triglycerides will be super high. And so we'll talk about that here in a second, how to recognize that. And then the next most common, which I have in parentheses here, is because it should be in between primary and secondary, are the polygenic type high triglycerides. These are usually not due to a single point mutation. They're usually due to a whole bunch of tiny small gene mutations that we call single nucleotide polymorphisms, and they're exacerbated by the environment. So your social determinants of determinants of health, insulin resistance, the diet, those will make your triglycerides go high. So the big difference is monogenic dyslipidemia usually will make your triglycerides up in the thousands, versus polygenic dyslipidemias will make your triglycerides anywhere from the mild to moderate range. And then the secondary type classifications, again, the most common one usually has to do with some sort of metabolic dysfunction, obesity, and insulin resistance. So here's the one that we want to rule out. So this is the monogenic genetic type hypertriglyceridemia that we call FCS, so familial chylomicronemia syndrome. So it usually has to do with some point mutation that causes the lipoprotein lipase to not work very well. And so you should be suspicious when your triglycerides are at least 1,000, but usually most of the time they're like 2,000 or 3,000. So it's not subtle, but this is what, this is the stuff in terms of the lipid specialists. These are the ones that we need to take care of, okay? So it has a higher risk for pancreatitis, and they do have a medication now to help to control that, which is the ApoC3 inhibitor. So as I mentioned before, ApoC3 turns off that pathway. And so now they have an inhibitor for that. And so they give the medications, and then down the pathway a little bit, the hepatic lipase is able to clear those elevated triglycerides. So FCS, that's the monogenic type hypertriglyceridemia that we need to worry about. The polygenic, so this is your differential here. So the most common one is the familial combined dyslipidemia. Some people call it mixed dyslipidemia, or it may be obesity-associated hypertriglyceridemia. So this is probably the most common one that the pediatricians see, and sometimes they will call it mixed dyslipidemia or obesity-related dyslipidemia. So high total cholesterol, high triglycerides, and low HDL. But again, this is not usually due to a single point mutation. This is usually due to small nucleotide polymorphisms that's exacerbated by the environment. So insulin, diet, their activity level, social determinants of health. And usually these levels are usually the mild to moderate range, and not in the severe, the thousands to 2,000 range. So just a quick reminder. So monogenic high triglycerides will happen before the liver. So what we usually see is that chylomicrons are big. They're very, because the lipoprotein lipase is not working, then you'll get some sort of down effect, and these other ones will be mildly elevated. And then polygenic usually has to do with some sort of substrate from high insulin, obesity, diet that's affecting the liver. And so the liver is starting to spit out more VLDL cholesterol. And so that's in terms of the metabolic pathways. That's one way that you can think about it. So as I mentioned before, the particles that we worry about in the states of high triglycerides are TRL, so triglyceride-rich lipoproteins. And some people will also call these remnant lipoproteins. But these are the ones that we want to try to recognize that are at risk due to them being atherogenic particles. And what basically happens is that the system gets overwhelmed, their lipoprotein lipases starts to be overactive, and it starts to cleave basically the fat of these large lipoproteins. And then what you're left with are what we call these small density lipoproteins. And as I mentioned before, the thought is that these smaller dense lipoproteins are easier to penetrate the vessel and then set up the cascade for inflammation and a fatty streak. So this is the nice table that the guideline provided. And if anything, this is one of the ones that I would take a picture of because you'll probably use this in your outpatient world. But it's nice because it breaks down mild to moderate to severe. So, so acceptable is less than 130. I use 150-ish. And again, it's usually due to VLDL triglycerides. Here I highlighted here, this is probably the most common pattern that we see in the outpatient world. So 130 to 400. And I was even surprised. For me, I would say moderately high triglycerides would be at least 300-ish. But in the guidelines, they're up to 400. And so a lot of times I think the pediatricians would wonder, because they would send me a triglyceride of 200, I put borderline mild. They're like, that's mild? But you can see even in this guideline, even up to 400 triglycerides is considered mild, okay? But here, this is the part that's really interesting. The treatment threshold from this guideline is not even considered until it's at least 400, okay? So that gives you a little bit of insight how difficult it was in the past to make a decision whether or not to treat or not treat. And then, severely, which usually has to due to some point mutations, so some sort of monogenic dyslipidemia. So thousands, 2000s, and those aren't going to be subtle. If you're an outpatient pediatrician, you'd be freaking out. So again, first line of treatment will always be lifestyle intervention and modifications. So that includes weight management, diet, exercise. So we want to reduce our simple sugars, our refined carbohydrates, our high glycemic foods, our trans fat foods. And so this will reduce the effect on the liver to produce large VLDL particles. So what do we want to recommend? We want to recommend fiber, complex carbohydrates, polyunsaturated foods, and omega-3s. And then according to the guideline, they suggest a referral to a dietitian if the triglycerides are still continuing in the moderately elevated range, so 400 and above. All right, so here are these nice tables that kind of lays everything out. And this is what I like the best because it starts to make sense a little bit. So it starts off with initially with the initial lipid screening. And so for us in pediatrics, usually most of the time, it's usually non-fasting, right? It's very hard to get the kid to get a fasting sample. But so it starts off non-fasting, non-HDL. So if your non-HDL is greater than 145 or your triglycerides are greater than 200, then you would suggest repeating it with a fasting lipid panel. And again, it's important because the decision to treat is really based on a fasting lipid level, not a non-fasting lipid level. So the first category acceptable, that's the easiest. It's less than 130, 150, promote healthy eating lifestyle, no medications needed. This one's the important one because again, I would say this is probably the most common reference pattern that we see in the outpatient world. So triglycerides between 130 and 400. We make our recommendations for lifestyle, diet, exercise, weight loss. Okay. So when do we start medications? We check non-HDL. Your non-HDL is greater than 145 or abnormal, then you want to consider, or it's reasonable to consider a statin medication. Okay. If it's not, then you continue with your lifestyle modifications. Moderately, 400 to 900-ish. Same thing, you make your lifestyle recommendations. But here, now we switch from a statin to a fibrate, okay? So if your non-HDL is normal, you can consider it a fibrate. It gets a little tricky if your fibrate and your non-HDL, or if your triglycerides and your non-HDL are both elevated at the same time. So in this situation for me in general, if my non-HDL is kind of borderline, then I'll just start a fibrate. Again, depending on which is higher. So if a triglycerides 800 and my non-HDL is kind of borderline, then I'll just start the fibrate. But if my non-HDL is super high and my triglycerides are super high, then I'll start the statin, okay? So that's the big difference. So that mild to moderate. Mild statin, depending on your non-HDL, moderate fibrate. Severely, again, you guys probably won't manage this. You'll be asking somebody. These are like in the 2000s. So what is the indications for pharmacotherapy? And so, and just to remind us, so there's no official FDA-approved medications. Again, just like everything else we do in pediatrics, everything is off-label use. So the first one, acquired or secondary high triglycerides with triglycerides persistently greater than 400, which sounds pretty high to me too. So for me personally, until this guideline came out, I would say 300 was sort of my threshold. That is refractory to lifestyle modification or management. So depending on who you read, anywhere from 2 to 6 months is considered refractory after those modifications. Or they have genetic type high triglycerides and have a higher risk of pancreatitis. Those are really the only two indications to treat. So what medications do we have? So the primary medications for elevated triglycerides are fibrates. We have fenofibrate and gemfibrozil. The mechanism of action usually has to do with enhancing the lipoprotein lipase enzyme and decreasing the production of VLDL in the liver, okay? Fenofibrate is the preferred medication because gemfibrozil has interaction with a statin, can cause myositis. So we tend to use fenofibrate as our first choice. Niacin is an old drug that's really nice to use in the setting of high triglycerides and low HDL because it actually raises your HDL. The problem with niacin is that you get this cutaneous flushing and most people can't handle it. But I've worked with a lot of gray hair cardiologists that use niacin in the past, and it works really well. It works well in the adult world, but it's hard to use in the pediatric world. And then omega-3s, and we'll talk about omega-3s here in a second. In the lipid world, there's a difference between omega-3, pharmaceutical omega-3s, and fish oil. Fish oil is considered an over-the-counter supplement. And I would say in general, that's what most general pediatricians use. In the lipid world, they do not recommend using over-the-counter fish oil because of the artificial ingredients. It's not FDA approved. And so despite what the labeling says, we don't know exactly how much omega-3s are actually in those over-the-counter supplements. Some people estimate that you probably have to take the 30 to 40 of those tabs just to get 1 gram of the omega-3 effect. And the starting dose for omega-3s in pediatrics is 2 to 3 grams. So statins. So we would use statins in the setting of mild to moderate high triglycerides when your non-HDL is elevated to lessen the burden risk for atherogenic particles. So if your non-HDL is greater than 145, it's reasonable and you can consider to use a statin. By the guidelines, 8 years and older, they've shown to be safe. That's the side effect profile. The way that we use statins based on intensity. In general, the way that I usually approach it, I usually start off with a moderate intensity statin. So I can keep my high intensity statin in my back pocket. If they're not controlled, then I can always go to the high intensity statin in the future. Most kids, they tolerate pretty well. I always start low and then work my way up. I can't even think of any problems that I've had with kids with a statin. Most of the biases that families have with the statins because a previous family member is taking a statin and they've had issues with it. But I haven't had any problems in the pediatric world. So omega-3, slash fish oils, whatever you want to call them. There's only really been 2 big, large randomized trials in pediatrics. And as I mentioned before, the goal to treat triglycerides is to lessen the risk of pancreatitis and to lessen the risk of atherogenic particles. But here in this study, you can see that in the last 2 studies, using omega-3s had a little effect on lowering triglycerides. The most important thing here, which is down here, had no effect on LDL particles. And as I mentioned before, that's what we're really trying to prevent, the risk of developing atherosclerosis. So in these 2 trials, it showed that they didn't have any effect on LDL particles, so the risk for atherogenic particles. 2 years ago, the AP released the obesity guidelines for pediatrics. So as I mentioned before, obesity management is really a big part of triglyceride management. And a key action statement is that all all providers should offer or recommend obesity-related medications at 12 years and older. And they made a very controversial statement that normal watching, we need to be very aggressive in treating obesity now. So that was their controversial statement from that guideline. And so as you guys know, most of us know GLP-1s in the adult world, but we now do have an FDA approval for GLP-1s in pediatrics, 12 years and older. So it's very effective. So I'm actually pretty lucky because I work additionally, besides here at PCH on the reservation, so I work at the Indian Health Service, and they have their own formulary, and so it's a little bit easier for us to get GLP-1s in the pediatric world there, but it has made a huge effect on metabolic dysfunction. But here too, you can see the effect that it has on triglycerides here, so they work extremely well. Exciting thing too, just recently, they just came out with the oral version of GLP-1s. But they're not yet approved for the pediatric world, but it's only going to take a couple more, I would say months probably when that's going to happen. So kids will no longer have to be injected. But I think it probably still has the same side effect profile in terms of like the nausea and not feeling very well. But the GLP-1s work. And the other thing that's exciting about the obesity medication world is that there's other medications that are still coming out that are probably going to be a little bit more efficient than the GLP-1s. All right. So now here's our question. So hopefully we can get it right. So family history, you send for a lipid screening, and this is what you get, triglycerides at 233. And so the question is, what biomarker would we send to assess for atherogenic particles, and what medication would we use? So we got 6 choices. So elevated non-HDL over ApoB ratio, we use the fibrate. Elevated triglyceride to HDL ratio, and we use a PCSK9 inhibitor. Elevated total cholesterol to HDL ratio, we use a statin. Elevated hemoglobin A1C to triglyceride, and use a GLP agonist. Or elevated non-HDL and ApoB, we use a statin. Or elevated PCSK9 level, and we use lipid apheresis. So that's the question, and hopefully everyone will get it right. So I think you have to scan this thing. Yeah. Oh, okay. So you go to the next one? Okay. Oh yeah, sorry, there you go. If we get 100%, I'm dancing for you guys.
While waiting for response,
Yeah.
I still see some. But the American Academy of Hypertension, hyperlipidemia, A1C, those all fall under there are these universal recommendations. And do this and do that. Okay, so you do your screening, it's fasting, it's in the treatment threshold, and yet the guideline drops off there and says, consider referral, consider this, consider that. I mean, if every one of us did nothing but preventive cardiology, we still could not see the number of patients that would qualify. So is there like a sheet you can download, a checklist, a cookbook to get a primary care physician started?
Yeah.
Okay, this is, okay, we did all the lifetime.
Yeah.
Right.
Correct.
Still high, we
Yeah.
needed it.
Correct.
Okay, it is under the realm of the primary care person to start this minute, check blood levels this often.
Mhm.
They're comfortable doing behavioral medicines.
Yeah.
Simple medications like this somehow result in a cardiology referral instantly.
Yeah.
And we just can't do it.
Correct.
So at what point, I mean, obviously with the monogenetic stuff and your
Yeah.
cholesterol's in the thousands, that's a no-brainer.
Correct.
That person has a serious genetic disorder. But this is primary care.
Right.
So where do you say, okay, this is what you try first, I will help you. Here's a sheet you can download from our website. We do a obesity conference once a year.
Yeah.
I went to Boston for cardiology. My total training in preventative cardiology was 4 one-hour lectures, one each year.
Yeah.
Okay, so I'm no more qualified than a pediatrician is.
Yeah.
So where do you start, and then where do you say, okay, now I've done my stuff, and now I refer?
Yeah. Definitely. That is an issue, and I think as you mentioned before, our knowledge and awareness and our management style has progressed over the last 15 to 20 years. And as I mentioned before, the last lipid guideline was in 2000. So that was 15 years ago. Very good at, we should recognize LDL cholesterol. That's the primary, but the most common thing that we see is the high triglycerides. So with this new guideline, hopefully it'll help a little bit. And that's why
And that slide, moderate, it's consider referral to a lipid specialist.
Correct.
Okay?
Yeah.
That's not enough.
Correct. And again, I just think it's the same thing with when we had ADHD medicines. I mean, we were comfortable in doing the Ritalin, but then when the Adderall, Concerta, and all that stuff came, I think people were very shy. And even when I was a pediatrician doing monotherapy ADHD medicine, I felt comfortable. But even now, we've all seen when they these patients come, they have like 2 or 3 ADHD medicines. So I'm like, man, that is crazy. I would never be putting someone on without that referral. But I've seen pediatricians now starting to add those. And so I think it's going to take time for them to start to feel comfortable. And again, we're still trying to, and so that's why we're here today. We're trying to make that awareness that they can start these cholesterol medications. But I still think, yeah, they're very uncomfortable, and hopefully these guidelines will help. The other little broad issue too is that we need to update the global pediatric lipid guideline, because it's been 15 years. So everything was sort of loosey-goosey in terms, because it's the same thing. They had like 1 moderate, 1 severe, do this and that, plus family history, think about treating. It's too confusing, you know. So hopefully those new lipid guidelines for pediatrics will come in and they'll alleviate that issue in the outpatient world. Yep.
Is ApoB part of the standard lipid panel?
No, you have to order it separately.
And if not, then should we always be ordering that as well? You think that's helpful, or?
So it's got a moderate strength recommendation, but it does definitely give you a good insight. You know, I usually, well, I mean, this is what I do. So it's nice because it really helps when you have that discordant levels from the traditional lipid panel. Because if your ApoB is high, then you know it's real. Then you're like, okay, either then you know, like, yeah, I am gonna send it to endocrine or me, or it's normal, and I'm like, okay, I feel fine. It's the triglycerides are 200-300, whatever. I could have them come back or follow up their pediatrician, you know. So that's why I like to use ApoB as a whole. Yeah, but that's kind of up your provider choice, I would say. All right. So 61%. So no dancing.
Advance once more so it's clear. It's the arrow once, then I'll go ahead and green.
Oh, okay. Oh yeah. There you go. All right. All right. So non-HDL. All right. Yay. Oh, let's see. All right. So here. So answer E. So elevated non-HDL and ApoB. So we use a statin. So this person had triglycerides at 233. So that's in the mildly elevated range. So 248 minus 31, we get a non-HDL of 217, and normal non-HDL is less than 145. Okay. So we can use non-HDL as a calculated estimate of atherogenic particles, or we can measure ApoB specifically to get that actual number. And the medication of choice would be a statin, because we want to reduce the burden of atherosclerotic potential. And then lastly, you know, there's been speculation for a long time that Mona Lisa actually may have died from having high cholesterol. And how many times have we all seen this image? And maybe some of us have actually been to the Louvre and actually seen this question, but seen this image. But the evidence has been staring at us for the longest time, and I don't know if anybody sees it, but there's evidence that she may have had high cholesterol. And there are some people think that little spot maybe is xanthoma and that she had a little lipoma there. But there's been a lot of articles about that and how she actually died. But little cool fact. All right, cool. Thanks for your attention. And I don't know if we have any more questions.
We got 1 or 2 more minutes left. So one quick question. The thing that would really convince general pediatricians that we need to be starting these meds, which I think we should, but you know, how do you do a double-blind trial where you start a medicine in a teenager and you're looking for, you know, longevity, you know, 60, 70 years later?
Yeah.
I mean, is anybody ever trying to do that? You know?
Yeah. So we actually have 3 good markers for lifetime risk. And those came from a little bit from Bogalusa and the muscatine study. So the first one we have is chronically elevated estimated non-HDL. Again, a surrogate marker of atherogenic particles. We also have ApoB, again, the more specific marker for atherogenic particle. But the one that we have that's really more specific, and that's a whole different lecture, is lipoprotein little a. Lipoprotein little a is now the new molecule that everyone's worried about. So it's an LDL-like particle that's genetically transmitted. I often like to think about this in the situation when you hear a family member who had an early heart attack in their 20s or 30s, besides having an LDL high, they usually had a high lipoprotein little a. Okay. Right now, we don't have any specific medications to treat lipoprotein little a. In the adult world, they're working on it. But right now, it's either you have it or you don't. And if you do, it's lifetime, the lifetime risk. And so and there's actually articles in the pediatric world. It's recommended that everybody get a lipoprotein little a measured at least once, because it, as I mentioned before, either you have it or you don't. It doesn't change from your diet or exercise. The number stays basically the same. In terms of like treatment for lipoprotein little a, is really right now in the pediatric world is really based on your LDL concentrations and your ApoB. So if those are normal, then we just sort of watch them. Okay. But in terms of like longitudinal effect, so it'd have to be either those 3 markers with other things, things that you're evaluating and see what the long-term effect is.
I mean, the ideal would be a double-blind study where if you could put a bunch of teenagers on, you randomize them and some of them get meds and some don't.
Yeah.
And really prove that because, just because you started med as a teenager, are they going to take it for the next 60 years and all like that?
Yeah.
It's probably
I would argue that you don't have to do that stuff.
Well, right.
I mean, think about the HIV saga. I mean, at first they looked at, CD4 counts, and then they said that that's your disease marker. And people that did better, had higher CD4 counts. And then they came down to, viral load. And viral load became your disease marker. And just by suppressing your viral load, you then improved survival because we had a biologic marker of disease activity. The Bogalusa trial proved that, atherosclerosis kills people. Okay. But we have a marker for disease activity. And if we treat that marker and optimize that marker, we're going to get the outcome. We don't need to, reinvent the wheel.
That's what a lot of adaptive clinical trials and things have shifted away from direct patient effects and towards looking at biomarkers that correlate tightly.
Coronary artery disease. We do not have a cheap, fast, safe, and effective screen for adult coronary artery disease. I mean, maybe electron beam CT calcium scoring is close because it's not invasive, but the best thing is intravascular ultrasound. You're going to float a catheter down somebody's coronary artery just because they have a cluster of 300? No. But we know the disease markers, and we treat the markers. Primary prevention, start on medications, do this, and then we know we're going to influence the outcome.
Yeah, in the adult world, it's calcium score and ApoB now, and they're really pushing that they in the adult world the lipid levels need to be like in the 50s and 70s now. So that's what was really confusing in the previous 2018, that there was no threshold of how low, which now it's go as low as you possibly can, which is different in our pediatric world. Because people kind of hear that and they're like, should we start making their cholesterol super low? But as I mentioned before, that's why I put up that slide that cholesterol still has, biological roles in puberty. So I try not. And so when I talk to other people, it's just more important that they're on something to help to control that. Because in my general experience, especially when we start a cholesterol medication when they're younger, is I always tell the parents, and I see this because I see this with my own kids. Once they get their phone, they starting to make some money and they have their own car. The parents have lost that way of controlling their diet, basically, because my kids order basically everything on an app now. I mean, the time that I come home, they're like, I've already eaten. Because they have their money and they can get. And then next thing, my kid's going through starting college. When you go to these college places, they have Chick-fil-A, they have fast food inside their dormitories. And so it's very hard for a college person to try to eat healthy. In fact, a lot of the kids, I still actually manage some of my kids in college, and it's very hard for them to keep their diet straight.
Okay, well, we need to let the residents go back to the words. We got one more thing you can answer while they're going. How do I get the profile with the U of A? Oh, no, that's probably a CME question.
Oh, yeah.